Welcome to Infection and Immunity Evidence Explained, a Doherty Institute podcast. I'm Rebecca Elliott. For the episode published on the 5th of January, we had the authors of the book Life as We Knew It, the ages Aisha Dow and Melissa Cunningham, on as our guests to talk about Australia's extraordinary pandemic story. Aisha and Melissa kindly donated a copy of their book for us to give away, so we asked listeners to write in and suggest a topic for future episodes, and the winner was Bill Rankin. His topic was, how do we diagnose and treat post-infection disease like long COVID, and how do we add this aspect to our future pandemic preparedness? And today, we're bringing you that episode. Joining me on the podcast to unravel this topic is Professor Lena Sanci, who is the head of the Department of General Practice and Primary Care at the University of Melbourne. In addition, Lena is a long COVID project leader for the Australian Partnership for Preparedness Research on Infectious Diseases Emergencies, or a PRIZE as it's more commonly known. Lena, welcome to Infection and Immunity Evidence Explained.
Thanks, Beck. It's great to be here.
So firstly, what is a post-infection disease?
Yeah, so certainly we're hearing a lot about these now, and post-infection disease refers to a medical condition that includes all of the symptoms that happen after you get that acute infection and any of the long-term health effects that are caused by that initial infection.
And so can it be any type of initial infection that can cause a post-infection disease?
Yeah, that's a good question. So it has certainly been observed in certain other viral infections. So we know about COVID and leading to long COVID, but other common viral infections that can cause it are like RSV, the respiratory syncytial virus. There's other more exotic viruses like Ebola and dengue and even polio, and even influenza viruses can. And a common one that we know about for teenagers is the Epstein-Barr virus or glandular fever. They can also have been noted to cause these infections, but even there are some other non-viral type infections such as Giardia, which can cause gastrointestinal upset, and Q fever and Lyme disease. There's some other types of things. So I don't think it's observed in every infection, but these certain types of infections have been noted to lead to post-infection disease.
What are some of the most common post-infection diseases?
Yeah, so I think commonly they occur in a minority of patients too, I must say, after all of these infectious syndromes. But some of them are, for example, a lot of people will have heard of myalgic encephalomyelitis, which is ME, or chronic fatigue syndrome. They're common post-infectious disease syndromes. POTS disease as well, postural orthostatic tachycardia is another manifestation. And yeah, so they're probably, and also sometimes various gastrointestinal disturbances can lead to things like irritable bowel syndrome, which might also be a manifestation of an acute viral infection and one of the longer term consequences as well.
And when you have an infection, is there any way to tell if you'll go on to have a post-infection disease?
Yeah, well, I think that there isn't, but there are some particular risk factors that have been observed with some of them. Unfortunately, it's an area where there isn't a lot known about what actually causes these syndromes, and there's a lot of research going into it. And I think the advent of long COVID has attracted more research interest into this area. So could the research that's going on into the causes of long COVID could actually improve our understanding of these other ones. Yeah, so when we look at the risk factors for long COVID, where we're getting a lot more understanding of these things, that can certainly manifest in people across the lifespan, so children and to older adults can get it, and across races, ethnicity and gender and so on. And it is a very complex sort of disease that happens in multiple systems of the body. So there does need to be a bit more research, but certainly we're thinking now, the field is thinking that long COVID is a disease with many different subtypes, and each subtype would have different types of risk factors, and they might be something to do with your genetic inheritance or the environment in which you're living. And there's probably distinct biological type mechanisms that respond differently to different treatments. So all of this is really under investigation. But the classic form of long COVID that people often hear about, where you have brain fog for, over 3 months, where you can't think clearly or compute or remember things well, fatigue type syndromes where even if you rest, you're not refreshed, feelings of palpitations or feeling lightheaded, having extreme fatigue after doing any form of exertion. That classical form has tended to be a bit more common in younger adults and females. And other forms where there are more cardiac type conditions or breathlessness seem to be more common in older adults who have other diseases already. And they're a little bit more prone to some of the ones that to do with the specific organ symptoms. Initially, certainly that people say some of the, when we were first looking at the cases of long COVID coming out, the more severe infections tended to were more likely to cause long COVID. But they're now saying that more than 90% of the cases of long COVID are actually due to milder infections, because milder infections are much more common. And long COVID is an uncommon outcome of COVID, but because we have more and more milder infections, we are seeing long COVID even in these people. But it's generally accepted that the more severe the infection, the more chance you've got of perhaps it going on, even though it is still a lower prevalence. And also in the early days, we were observing associations with some ethnic minority groups that were, and possibly because they were getting more of the COVID, and smoking or being an ex-smoker or being in the overweight age ranges were also sort of risk factors. But I think there are many more, because we're understanding about the different subtypes. There's probably more to find out about who's most at risk.
What are the most common symptoms?
So the most common symptoms, so first thing to say is that long COVID is a multi-system disease, and as we've been studying it over time, there is many symptoms that are associated with it. It's very hard to narrow down just on a few. But perhaps the most common are a really persistent sense of fatigue that's really unrefreshing sleep, not feeling refreshed after sleep, feeling persistently tired, and it's whole body tiredness, not just the tiredness of not sleeping. Breathlessness is another common symptom. Headache. Some people experience a chest heaviness, which needs to be differentiated from more serious things like heart attack. Muscle aches and pains and palpitations can be there. And then this brain fog, which is really like a poor memory and poor concentration. Some people get cough and mental health symptoms, but most of the characteristics are that it affects quality of life and functioning in day-to-day life. It could be at work or at school, at home, and the duration and the severity of these things differ. But generally, a lot of the studies are putting the syndrome of long COVID at 12 weeks or after, even though people might start percolating a few of these symptoms a bit earlier than that.
So how is long COVID actually diagnosed?
Yeah, so it's sort of again, I think we need to know much more about that, because it would be a lovely thing if we could do a blood test and say, well, you've got long COVID. But unfortunately, there isn't a single diagnostic test, and there aren't any tools or anything like that to confirm a diagnosis. So you do have to think about the person's context and how they've got their initial infection, and what were the other things going on before they got an infection, and how have those been affected afterwards, and look at the impact on everyday functioning. And you certainly, when you're assessing people, you're looking for red flags of very serious manifestations. So things like severe, new or worsening shortness of breath or low oxygen, fainting, unexplained chest pain, any palpitations or delirium or things wrong with the nervous system. These sorts of things would indicate they need an urgent assessment, and they could be resulting from the infection, but they're probably explained by other manifestations of infection and not long COVID. So it's sort of a diagnosis, a little bit of exclusion when you understand the person in their context, their function is severely affected, there isn't anything else really serious going on in the organs that can be explained by something else like a pulmonary embolus or a heart attack, or you certainly don't want to miss any of those things. And once you've ruled out those sorts of things, you might do some blood tests to rule out other things that might not be easy to see. So, you would do a blood count, you would check kidney function, liver function, indicators of inflammation, blood sugars, we check the thyroid, iron, and those things. And then look at people's exercise tolerance. So typically they're very tired even after short bursts of activity or more breathless. You'd measure their oxygen saturation to make sure it was still in normal ranges, and perhaps measure blood pressure for any drops when they go from lying to sitting, and do chest x-rays or other imaging, ultrasounds, to rule out some of those red flag conditions. So if you've ruled out the red flag conditions and you have these symptoms that are really affecting people's level of functioning, then that's more likely to be due to long COVID. And you've also reached the time frame at which we would be thinking about that.
So at what point would a person actually seek medical attention for some of these symptoms?
It's a good question about when to seek medical attention. I think it really depends on how the level of function is being affected. So in the early days, when my colleagues who work in respiratory clinics and have other GPs that have set up their own long COVID clinics, usually say that people might be experiencing symptoms of their acute infection really up until anything from 4 to 8 weeks. You might almost accept, providing it's not really severe, that where you have to rule out the red flags, you might almost accept that that's a long history of symptoms, but it's not yet long COVID until you've got past the kind of 12-week mark. But having said that, if they get to any point in time where they really feel, I'm not able to function well, I need some time off, I think it's good to check in at that point and have an assessment. And there's no harm in that, because you do have to make sure that people aren't having other manifestations of COVID where they might be getting some of the lung injuries or brain injury or other organs being affected. So get checked out, and then there'll be a monitoring period. But if the symptoms then persist, even though investigations are not really showing up that much, then it's a case of monitoring and trying to intervene.
Do we have any treatments yet available for long COVID? We'll have the answer to that question in a moment, but just a quick break to say that if you're enjoying the podcast, why not share it with your family and friends, or rate and review it on your favourite podcasting app? And now back to the episode.
Right. Well, there aren't actually a lot of treatments. So I think the first thing at the moment, and this is really the great area of research, and there has been a $50 million investment in research for long COVID, and a large proportion of that has been devoted to looking at what markers might be there to indicate long COVID and how we then tackle the treatments. But there are some emerging promising ones, and certainly, and more will probably evolve. But I think the first thing to say is that prevention is probably the best thing. And the protective factors against long COVID are, by and large, good public health measures, which I'm afraid to say most of society has thrown away now. We seem to have abandoned the mask and the 1.5 distance and all of these things, which is kind of a little unfortunate when we're getting to a season of winter where the viruses are in abundance. So if it were me, I think on crowded public transport and that sort of thing, I might be inclined to try and protect myself from gaining lots of viruses. But putting that aside, given that we're not doing that much, vaccination is probably the first line of defence. And the vaccines certainly reduce the risk of long COVID by anything from between 15 to 75%. And the latest studies are with a mean of around 40%. So you can reduce your chance of getting long COVID by up to 3/4 by having your vaccines up to date. And the other things that if you're,
Wow.
yeah, which is amazing, isn't it? So it's a bit of protection that we can do for ourselves. And certainly in the age groups, the over 50s, antiviral therapies within 5 days of onset, that can increase the risk of long COVID by about 26%. So certainly that's most applicable to those over 65, but I think they did bring it in for younger ones too. So your GP will be able to consult about that. And certainly if you've got any other illnesses, it's good to get assessed for whether you're eligible for treatment of COVID itself. So that's prevention of long COVID. But if you've got long COVID, what do you do? So the treatment goals are generally trying to manage the symptoms the person's experiencing to see if we can improve the function that they have as best as possible and their quality of life. And it does mean integrating care from multiple different healthcare providers. So it's a time when we really want coordinated care and whole person care. So someone being able to sit, and often this is where a GP or primary care can be the first port of call. There should be no wrong door, by the way. So other primary carers that commonly manage long COVID are physiotherapists as well. But I think if you see your local doctor as soon as possible, there should be a lot of listening going on around what your symptoms are, how it's affecting life and function, and then providing some education and support for what long COVID is, assessing people for the red flags that I described before, and arranging the appropriate tests and investigations to rule out these other dangerous causes of symptoms. And then also, if they have any other chronic condition, that needs to be optimally managed. So if they have chronic, airways disease, for example, or cardiovascular disease, you really want to make sure, asthma's controlled well, diabetes controlled well, their heart failure is in good control, all of those sort of other things that might be going on. You want to optimize that. And then also look at the person's lifestyle. Are they smoking? Are they drinking alcohol? Are they getting appropriate nutrition and good sleep and a balance of physical activity? So obviously we want to stop smoking or reduce or cut it out altogether. It's not going to help. And drinking too much alcohol will also be not conducive to helping with this condition. A good balanced diet and adequate sleep. Now, physical activity really, again, depends on the type of long COVID they've got, and developing a management plan for the main symptoms really important. And some of the appointments with providers can be by telehealth or face-to-face, but you want to look at if someone's really very fatigued. It's quite helpful to visit a physiotherapist or an exercise physiologist and look at physical rehabilitation that's very cautious, because some people experience a worsening of symptoms with exertion. And so it's something that should really be paced and monitored according to how the person's feeling after exercise. And I think the GP needs to work with the physiotherapist or the exercise physiologist to assess what would be the best regime there. Apparently there are things like smell and taste retraining if that's disturbed, and there's certainly some breathing training.
Oh.
Yeah, I know. To be honest, I don't know much about that. So I'm not sure. I'd have to look at who does that, but I'd imagine that could even be in the field of dietetics, that you could get nutritional assessments there and work on that. But apparently there is good breathing training. So breathing training for breathlessness that encourages cycles of breathing in and out in a regular way, and other techniques like having the fan on in your face, and these sorts of things can relieve some of those senses of breathlessness. So, I would, if I was the GP in the position, and it really does vary with where you live as well and what's available, but it certainly is helpful to have the extended expertise of a physiotherapist or occupational therapist, the exercise physiologist, sometimes speech pathologist, dietitian. And because there's so much strain on emotional health and well-being, a psychologist is often also very helpful. And the GP can certainly do a lot of these things, but integrate with these other services is probably a good role there as well. Just to add, the other important role, I think that the GP might coordinate themselves or with a social worker is also to relieve some of that stress of day-to-day life with the person. Are there any supports available for them through the workplace where they might be able to do modified duties or perhaps have to take some time off, or in the education space, what sort of modifications could be made? I think that's the other thing. Do people need home help or other sorts of help to cope with day-to-day life while the symptoms are disabling?
Look, it's great to hear that there are so many services available to help with the symptoms of long COVID, but it sounds like it's quite a bit to navigate. So is our current healthcare system well equipped to support patients with long COVID, and how do they navigate that system?
Yeah, that's a good question, Beck. And I think at the moment, since the COVID pandemic, there's been a number of repercussions, and, long COVID is one of them. Mental health issues are another, particularly for young people. And the other thing is workforce shortage and workforce burnout. And I'm afraid that's also an issue in primary care and in secondary care. And so it is quite difficult, I think, to find all the services as efficiently as we would like them to be. I think also the best place to care for long COVID is probably primary care in general practice or the allied health clinics where we all integrate together. But we're in a bit of a state where our system doesn't support good multidisciplinary care. And it is in the planning that we have more changes to Medicare that move us towards funding doctors and nurses and physios and all those people to work as a team. There's a little bit of funding there to happen, but it doesn't come together as easily. But having said that, there are some brilliant general practice services out there and physiotherapists who are doing this work because they're meeting the needs of their community. They're just working this way because it's the right thing to do. And you will notice that they will be listening to their patients and facilitating coordination. So there are allied health in the community. It's just that sometimes they're hard to bring together efficiently and effectively, and in the public system and even in the private system to some extent, but it is a bit easier. So I do feel that we have a way to go with being able to properly fund the care of chronic disease in this country, but there is quite a lot of work underway to study what are the best models of funding multidisciplinary care in community settings.
So what advice would you have for someone who is trying to navigate the system?
I think for providing their symptoms are not really severe, that they need to go to emergency or anything like that, I think the general practitioner should be the first port of call. And I do hear out there that sometimes they don't get a listening ear. I think there is much more awareness of long COVID. There are guidelines for general practitioners in how to approach the management of long COVID. And I think that a patient can go informed also themselves with, they'd do well to be clear about when their infection started, how they were before and how they are now and how long it's been going on and in what ways it's affecting them. And really the GP should try and work collaboratively with their patient to do those things that I described before, to wrap around supports. And they and the nurse and the people working with them should be able to pull in or refer to other specialties as required for that person. So, maybe if you're going early, because we don't really tend to apply a diagnosis of long COVID, it's a bit of a arbitrary thing, but at the moment, until we get more evidence on this, we sort of apply it at around 12 weeks because a lot of people do actually get better from their symptoms up to 12 weeks. And even after, they're better by 6 months and better by the end of the year. But there are a small proportion that keep going on. So, the prevalence of this condition when COVID first started, before the vaccines, was running at around 10% of infections, and now it's down to about 1%. So we are talking that it's not a common outcome, but it might be common to have symptoms up to 3 months, but they will gradually, most of them will get better. So hopefully your GP can monitor you, and if things are progressing or your lifestyle's getting more and more affected, they're going to be swinging in the other supports and care as required. Rule out the other conditions that might be causing symptoms that are dangerous in the heart or the lungs or the liver or in gastrointestinal system. They'll rule out those things and be able to send you off to specialists if required. But by and large, they can manage your symptoms with allied health in the community. Perhaps I'm just, that's the system I know, but I would certainly go to your local doctor, your general practitioner as the first port of call to get that all started for you.
Great, thank you. Some great advice there. Changing tack slightly, can you tell me about your research that you're conducting into long COVID as part of a prize?
Yeah, sure. So we were very fortunate to come together. I'm working with Professor Andrew Lloyd at the Kirby Institute. So he and I are overseeing this project to look at, and we're bringing in a national group through a prize to look at what the pattern of long COVID is now in Australia, in the setting where we have new variants that are less severe. We have vaccination on board, and we have the use of antivirals. So we're in this different climate now. What is the amount of COVID that would turn into long COVID over time? So we're studying people who might come down with an infection, a respiratory illness of any sort, and we want them to contact us so we can put them into this trial. We give them a test to see that diagnoses a rat test that can pick up long COVID or flu or RSV, and we want a proportion of people who also haven't got any infection, and we're going to follow them up over 6 months to ask about symptoms along the way and do some tests in those that have persistent symptoms past 3 months to rule out other issues, and then see how many of them continue on past the 6-month mark and be able to describe that experience of infection that's prolonged and try and understand what types of long COVID might be emerging as a result of that study. We're also mapping some other studies underway who are already looking at people with COVID and long COVID to see they may have collected those groups of people prior to the later variants, so when there were more serious variants, and we're looking at the pattern of long COVID in those people as well compared to the more recent ones.
Great. And so how can someone participate in your study?
At the moment, we're selecting the states in which it will run, and we have been thinking that we will go out through general practice clinic populations to ask people to complete a test if they get infection, and through pharmacy outlets. And we will probably have a social media type presence as well for people it's an interesting one because we need them when they first fall sick. So when they first got their sneezes and they don't really know, or sore throat or whatever, headache or fever, when they don't know what it is they've got, we need them really early on in that time because we want to track COVID outcomes next to the other viruses to see how they compare over time, their outcomes. So we have a website on the prize website, a landing page for this. So they'll have to keep watch out for when we actively start recruiting, and they can contact us about it.
Excellent. Finally, Lena, what lessons can be learned from managing long COVID to inform future public health policies and pandemic preparedness?
Yes, it's a really good, it's a $1 million question, and certainly something that, I think so important for the future because we're likely to get more, isn't it? I think what we've learnt in Victoria, and in particular, and others have said too, is that we need localised approaches. I think the public health units and primary care networks need to really work together to locate groups that are vulnerable that wouldn't normally come to care or be able to listen to other communications, provide education and access to prevention. So the public health measures are really important, and we know they work really well and were life-saving before we got vaccinations, but also to explain about vaccination and mask wearing and all those sorts of things. I think we need education about the signs of early infection and what to monitor, and really clear pathways to assessment. And I know these things all evolved later in the piece, but the wonderful pivot that everyone in healthcare did towards telehealth models, having those, well, they are still available, they're continuing, but also the setting up of respiratory clinics where any sort of symptom you can go along to respiratory clinics in the community to be properly assessed and monitored. And I also think we can be aware that this syndrome might happen and have our primary care teams ready to deal with it, with lots more connection but with the other specialties within community. So I do think we have to really get that model of how we look after chronic illness of any type, with multidisciplinary team-based care, with your doctors, your nurses, your allied health, psychology all together. We really have to get that right before the next pandemic.
Lena, so many great insights today. Thank you so much for joining me on Infection and Immunity Evidence Explained.
Thanks, Beck. It's been great.
And thanks to all of you for listening to Infection and Immunity Evidence Explained, a Doherty Institute podcast. If you'd like more information on Lena's research, visit apprise.org.au. That's apprise.org.au. If there is a specific topic you would like us to cover, please get in touch with us by emailing doherty-media@unimelb.edu.au. That's doherty-media@unimelb.edu.au. If you've enjoyed our podcast, please rate and review on your favourite podcasting app and subscribe if you haven't already. The Doherty Institute is a joint venture between the University of Melbourne and the Royal Melbourne Hospital. See you next time.